So I typically go ahead and assess for systemic therapy after there is a confirmation of radioactive iodine refractoriness, where the patient has progressive disease in the last 6 to 12 months, either clinically or through radiographic imaging. The If there's systemic or bulky disease that's not amenable to surgery or local therapy, and the patient has a good performance status, and they have good organ function, I go ahead and try to assess for systemic therapy.
So there's sort of two settings. There's the patient who comes to me because they had bulky disease that was not fully resected at the time of surgery, or maybe it came back right away and they had radioactive iodine and the disease is too big to really expect a response. Or, they just had radioactive iodine and it was just growing anyway. So some people come into me with disease that's actively progressing. In those cases, I'll be considering, what's the rate of progression, how fast is it, what's their overall tumor burden, and very importantly, what the location of those nodules are. In other patients, sometimes they're growing a little bit slowly, and I get asked this question a lot as to when to start. There is a trial where we actually looked at it, and we did see that patients who started a little bit closer to those eligibility criteria did better than some patients who waited longer. I think that in general, the feeling amongst most of my colleagues is that waiting until symptoms is too late. If a patient comes in and they're symptomatic already from their disease, then they should start right away. But the question is, with the patients who are not symptomatic, what you want to do is you want to anticipate symptoms and you want to get it so that you're stabilizing or shrinking the disease prior to the onset of symptoms. And the reason for that is that when you actually treat them, if they have symptoms, they may not all go away. So even if the disease disappears, the cough that they've developed or the pleural effusion that might have happened may not be reversible. So even if the cancer is controlled, the symptoms might not go away. So it takes a little bit of expertise to see what that happens, but those are the things that I take into account: tumor burden, number of sites, location of sites, how fast they're growing. And certainly if they have symptoms, I would be starting immediately.
You have to make sure that the patient is always at the center of what you're doing. So you need to make sure that your patient is very comfortable in the treatment process and they're comfortable in using any kind of the treatments that you're offering. So first of all, having that conversation with the patient and understanding what their quality of life is and what their quality of life can be is very important. They are the ones that are going through the whole journey, and we're not always with them. It's very important to focus on what the patient feels, as far as what their expectations are, how their anxiety is, how they want to understand what's actually happening to them, and how they want to participate in their own care. I think that these are very valuable, as the patient is the central part of the entire patient journey.
The beautiful thing is that rarely is it an emergency to start therapy. So when I start seeing that the disease is growing, I will start having conversations with patients such as, do you have a wedding coming up? Are you going on a cruise? And we will start to make some plans, because when people do start on systemic therapy, I'm going to be monitoring them more closely and seeing them, much more frequently in the beginning to monitor for side effects. And that can be a little in the way of people's social life or family plans. So we'll start to make a plan where they'll have a good 2 to 3 month period where nothing really super important is happening, and they'd also be able to make more frequent appointments.